Okay, let's unpack this. Abdominal pain.
Hmm.
It's something that crosses every GP's path, isn't it?
Absolutely. Constantly.
And for you registrars gearing up for those fellowship exams, well, mastering this area is absolutely crucial.
Definitely. High yield topic.
It's fascinating, actually, looking back, John Dee in the late 16th century battling what he thought was the stone. And he was using these concoctions of white wine and powdered crab's eyes.
Wow. Crab's eyes. We've come a long way, thankfully.
Haven't we just? But it really highlights how far our understanding has developed. Yet the fundamental issue of that gut pain, it remains one of the most common presentations in primary care, still.
And what's truly remarkable, I think, is the sheer breadth of what abdominal pain can signify. It can be something, totally self-limiting, a minor
Yeah,
inconvenience.
like a bit of indigestion.
Exactly. Or it can be the first sign of a really life-threatening emergency. So for you on the front lines of general practice, the ability to rapidly assess and differentiate these possibilities, especially in acute presentations, it's just vital.
Absolutely vital. And that's really the core of our discussion today, isn't it? Navigating that diagnostic minefield.
Precisely.
Exactly. And we're not just skimming the surface here. This is a proper deep dive.
Hmm.
We're looking into how we classify abdominal pain, acute, subacute, chronic, and recurrent.
Because each category really prompts a different line of thinking, a different pathway almost.
Right. And we'll be focusing intently on the common and the critical causes of the acute abdomen that you'll encounter, both in your consulting rooms and those that will need surgical referral.
Yeah. And those statistics are quite telling, aren't they? In GT series, you see appendicitis, colics, mesenteric adenitis leading the pack.
Around 20% for appendicitis, 16% each for colics and adenitis, roughly.
But then you look at surgical referrals, and nonspecific abdominal pain is actually the most common reason, about a third of cases.
That's surprising, isn't it?
Yeah.
34%, followed by appendicitis at 28%, and then cholecystitis around 10%.
That stat about nonspecific surgical referrals, it does raise an important question, doesn't it?
What does it tell us?
Well, maybe about the inherent challenges in sort of nailing down the exact cause in primary care. Perhaps it underscores the limitations of our initial assessment tools sometimes.
Yeah, or maybe the difficulty in distinguishing conditions that mimic surgical emergencies early on. It highlights the need for a really systematic approach.
Definitely systematic. To avoid unnecessary interventions, but also, crucially, to not miss something serious.
Absolutely. And part of that systematic approach involves understanding some basic anatomy. That general correlation, upper abdominal pain, often points to upper GI issues, lower pain to lower GI. It's a starting point.
A useful rule of thumb, yeah.
But here's where our focus sharpens, especially for exam prep. Recognizing those key symptom patterns, the ones that are highly suggestive of specific condition.
Like the classic progression in SBO.
Exactly. Small bowel obstruction, that typical colicky midline, umbilical pain first,
Yeah, starts around the belly button.
then leading to vomiting, and then the abdomen starts to distend, that sequence.
Compare that to large bowel obstruction, where the pain might be more midline but lower down.
Gastric.
Distension often happens earlier, and vomiting can be quite a late feature if it happens at all.
And a really critical rule of thumb for anything potentially surgical,
Yeah.
pain generally comes before the vomiting.
Yes, that's so important. Helps differentiate from, say, simple gastroenteritis, where vomiting might be the first thing.
Pain first. Remember that.
And this naturally leads us to consider the patient's age and their risk factors. That's hugely important.
Especially in older patients.
Absolutely. In our older patients, for example, we have to keep mesenteric artery occlusion high on our differential,
Mhm.
especially with risk factors like AFib or known vascular disease.
The consequences of missing that, catastrophic. So a high index of suspicion is just paramount in that group.
Absolutely paramount.
So with all this complexity, how do we, as GPs, actually begin to formulate a diagnostic strategy? This is where we need to meticulously dissect the approaches for both acute and chronic pain. We'll draw heavily on those structured frameworks in tables 24.1 and 24.2 from Murtagh's.
Those tables are gold dust for exam prep.
They really are.
Yeah.
We'll walk through the probability diagnoses, the common stuff, but crucially, we'll hammer home the serious disorders not to be missed and the common pitfalls that can lead us astray.
And the 7 masquerades checklist. Can't forget that.
Definitely not. Those conditions like depression, diabetes, meds, even spinal issues that can present with abdominal symptoms. It forces you to think laterally.
Those tables, honestly, for anyone preparing for fellowship exams, internalize the serious disorders not to be missed, and the pitfall sections, they are key.
And the 7 masquerades checklist acts like a critical safety net, doesn't it? Reminds us to broaden our thinking. Consider those extra-abdominal causes mimicking something intra-abdominal. And to really make this clinically relevant, stick in your minds for exams and practice, we're going to work through detailed index cases, spanning the whole age range, pediatric, adult, geriatric.
That's the best way to learn, I think. Real cases.
We'll explore the pathophysiology, the why behind it, and the specific clinical features, the signs and symptoms you'll be looking for. So let's get started. Let's take a closer look at those diagnostic strategy models in tables 24.1 and 24.2 first.
Okay, so looking at acute abdominal pain, table 24.1, your probability diagnoses, the things you think of first might be, simple viral gastroenteritis, maybe uncomplicated constipation, UTI perhaps.
The everyday stuff.
The everyday stuff. But as we've said, the real focus, especially from a safety and exam perspective, needs to be on those serious disorders not to be missed.
Right. What falls into that category for acute pain?
Well, think cardiovascular events presenting abdominally like an inferior MI or a leaking or ruptured AAA.
Critical.
Absolutely critical. Then severe infections leading to peritonitis, perhaps from a perforated viscus. And critical mechanical issues, bowel obstruction, volvulus intussusception, ectopic pregnancy in women of childbearing age, always.
And the pitfalls. These are the sneaky ones, aren't they? The things that can easily trip us up in a busy clinic.
Exactly. Think about musculoskeletal causes like a rectus sheath hematoma or just a strain in the abdominal wall muscle. It can really mimic something intra-abdominal.
Yeah, I've seen that. Or referred pain, maybe.
Definitely. Pulmonary conditions like a lower lobe pneumonia can refer pain down to the abdomen. Herpes zoster before the rash appears. Even, as you mentioned, fecal impaction in an elderly patient can cause surprisingly severe abdominal symptoms.
It's a good reminder, isn't it? Always keep that differential broad. Don't anchor too early. And that 7 masquerades checklist really pushes that. Things like spinal dysfunction, depression, diabetes.
Yeah.
Not the first things you jump to for belly pain.
No, but you have to consider them. Now, shifting to chronic or recurrent pain using table 24.2 as our guide. The probability diagnoses often include things like IBS, functional abdominal pain, maybe chronic constipation.
Things we manage commonly in primary care.
Yes. But again, vigilance for the serious disorders not to be missed is key. Here we might be thinking about inflammatory bowel disease, Crohn's, or UC.
Malignancy, obviously. Colorectal, ovarian, pancreatic.
Yes. And the more insidious presentation of mesenteric ischemia, the chronic form, or even things like chronic pancreatitis.
And the pitfalls in chronic pain. What should we watch out for?
Overlooking dietary triggers is a big one. Food intolerances like lactose intolerance, celiac disease. You really need a detailed dietary history sometimes. Missing parasitic infections. Endometriosis in women.
Okay, that framework is really helpful. Now, let's move on to a really important area for GPs. Abdominal pain in children presents its own unique set of diagnostic challenges, doesn't it?
Hugely. Communication barriers, different common pathologies.
Let's start with something incredibly common in those early months. Infant colic. That regular, unexplained crying, typically babies age, 2 to 16 weeks? A frequent worry for new parents.
Very frequent. And historically, it was often just assumed to be abdominal pain, hence the name colic.
But the thinking has shifted now, hasn't it?
It has. While the name implies tummy trouble, current thinking suggests true colic in a baby who is otherwise, thriving with a completely normal physical exam. It's unlikely to be due to a serious GI issue.
So the clinical picture is key.
Absolutely. The typical age range, those characteristic episodes of prolonged, intense crying, often predictably in the late afternoon or evening.
The witching hour.
Exactly. And associated behaviors like drawing their legs up, going red in the face.
Right.
But crucially, between episodes and on examination, the baby is normal.
And management for colic, then, is really focused on supporting the parents, isn't it?
Primarily. Reassurance is huge, explaining it's common, it's self-limiting, the baby is healthy. Practical advice on gentle handling, winding, comfort measures like swaddling or white noise.
And looking after the parent's own well-being. It's exhausting.
Incredibly so. Encouraging them to take breaks, get support, medications like simethicone. The evidence is pretty weak, isn't it?
Very limited, yeah. Focus on reassurance and support.
Okay, moving to something more serious in young children. Intussusception. This has to be a priority diagnosis, top of your list. In infants and toddlers, typically between 3 months and 2 years old, presenting with sudden, severe, colicky pain.
What's the underlying mechanism here, the pathophysiology?
It's essentially telescoping bowel. One segment of the intestine, usually the ileum, telescopes into the adjacent segment, often the colon at the ileocecal valve. This leads to venous compression, edema, and eventually arterial compromise and bowel obstruction.
And potentially infarction if not treated.
Exactly. In most infants, it's idiopathic, meaning we don't find a specific cause. But in older children, you have to consider a pathological lead point, like a Meckel's diverticulum, a polyp, maybe a lymph node.
Okay. And the classic presentation, how does it look?
It can be quite dramatic. Sudden onset of severe intermittent colicky pain. The child might scream, draw their legs up, very distressed during the episodes.
But okay between the episodes initially.
Often, yes, especially early on. They might seem surprisingly well between the waves of pain, which might come every 15-20 minutes. Vomiting is common. As it progresses, they become more lethargic, pale.
And the classic red currant jelly stools.
That's a later sign, but highly suggestive when present. It's stool mixed with blood and mucus, caused by the venous congestion and mucosal sloughing. Don't wait for it, though.
No, definitely not. What about examination findings?
The child might look pale, anxious, especially during the pain. Palpating the abdomen gently, you might feel a sausage-shaped mass, often in the right upper quadrant, though it can be hard to feel.
Especially if they're crying intense.
Right. Also look for syndedance, that feeling of emptiness in the right iliac fossa, because the cecum has telescoped upwards. Bowel sounds might be hyperactive early on, then become diminished or absent. A rectal exam might reveal blood or, rarely, the tip of the intussusception itself.
And diagnosis and treatment.
Ultrasound is the key investigation. It often shows a target or donut sign. Treatment is usually non-operative reduction first, using a hydrostatic or air enema under radiological guidance.
Pushing the bowel back out.
Essentially, yes.
Yes.
High success rate if caught early. Surgery is needed if that fails, or if there are signs of perforation or peritonitis. And differentiating it from acute gastro is important. The pain pattern is usually quite different.
Okay. Next up in pediatrics. Acute appendicitis. More common in older kids and teens, but can happen at any age, right?
Absolutely. And diagnosing it in very young children or those with intellectual disabilities can be really tricky. Atypical presentations, communication difficulties.
What are the common features? Vomiting, fever.
Vomiting is pretty common, maybe 80% of cases. Diarrhea can occur in about 20%, which can sometimes muddy the waters, make you think gastro. Fever is usually low grade.
Examination is key here, I imagine.
Paramount. Gentle but thorough abdominal exam. Finding that point of maximal tenderness, often McBurney's point. Rebound tenderness, guarding. And a rectal exam is often crucial, especially to detect a low-lying or pelvic appendix.
Because a pelvic appendix can mimic gastro more easily.
Exactly. It can irritate the rectum, causing diarrhea, and the abdominal signs might be less obvious. That's a common pitfall. A CRP level above 50 can be a helpful pointer towards appendicitis, though it's not specific.
And imaging.
Ultrasound is generally preferred first in kids, no radiation. CT might be used if the ultrasound is inconclusive.
Right. Now, the great imitator, mesenteric adenitis. How do we tell this apart from appendicitis? It can be tough.
It really can. The history can sound very similar. Abdominal pain, tenderness, maybe a fever. But there are some general differences we look for.
Such as?
In mesenteric adenitis, the pain and tenderness tend to be a bit more diffuse, less localized than in appendicitis. Often less rigidity on exam. The temperature might actually be higher than you'd expect with simple appendicitis.
And less anorexia, nausea, vomiting usually.
Generally, yes. And a really important clue is often a history of a recent or concurrent upper respiratory tract infection, that viral illness causing lymph node inflammation throughout the body, including the mesentery.
Okay. Table 24.5 in Murtagh's has a detailed comparison, which is definitely worth reviewing for exams.
Absolutely. And treatment for mesenteric adenitis is just symptomatic, isn't it? Pain relief, fluids, rest, reassurance.
Right. Okay, finally in our pediatric section, let's touch on recurrent abdominal pain, or RAP.
Ah, yes, RAP. Defined as what? 3 or more episodes over 3 months or more? Severe enough to interfere with activities in school-aged kids.
That's the one. And reassuringly, most cases don't have an underlying organic cause, right?
Correct. Only a small percentage, maybe 5–10%, have an identifiable organic pathology. But it's absolutely vital we don't miss those. We need to be alert for the red flags.
What are the key red flags for RAP?
Pain that's well away from the umbilicus or pain that radiates, pain that wakes the child from sleep, nocturnal pain, significant associated symptoms like persistent vomiting, especially bilious vomiting, or significant diarrhea.
What else? Appearing unwell between episodes? Weight loss.
Yes, exactly. Failure to thrive, unexplained weight loss, blood in the stool, unexplained fever, abnormal examination findings like a mass or localized tenderness, these all shout organic cause.
And what might those organic causes be?
Things like chronic constipation is a common one, urinary tract issues. Sometimes migraine equivalents can present as abdominal pain, lactose intolerance, coeliac disease, giardiasis, or other parasites. Less commonly, IBD.
So, if the red flags are absent, what's the typical picture of non-organic RAP?
Often described as acute, frequent episodes of colicky pain, usually centered around the umbilicus. Tends to be short-lived, less than an hour usually. Crucially, it doesn't wake them at night.
And the child is well between episodes. Examination normal.
Exactly. Minimal tenderness on exam often looks entirely well. You might pick up on anxiety either in the child or the parents or both. Sometimes a family history of functional pain syndromes.
Management here is quite different then.
Very different. It revolves around careful explanation after a thorough history and exam rule out red flags. Reassurance is key. Acknowledge the pain is real for the child, but explain it's not dangerous. Avoid excessive investigations.
Identify stressors maybe? School, home life.
Definitely. Address any underlying stressors. Encourage normal activities. Discourage the sick role. Sometimes simple measures like ensuring regular bowel habits help. Referral might be needed if symptoms are severe or persistent, perhaps to pediatrics or child psychology.
Okay, great overview of the pediatric side. Now, let's shift gears to abdominal pain in older people. The landscape changes quite significantly here, doesn't it?
It really does. Different pathologies become more common. Vascular events, malignancy, diverticular disease are much more frequent. Duodenal ulcer, interestingly, becomes less common.
And diagnosis can be harder.
Yes, for a couple of reasons. Their pain threshold might be higher, so they might not report pain as intensely. And their physiological response to infection or inflammation can be blunted, meaning they might not mount a fever or have a significant rise in their white cell count, even with serious infection like appendicitis or cholecystitis. Non-specific symptoms like confusion or just off legs might be the main presenting feature. Makes it challenging.
Right. So let's talk specifics. A critical vascular emergency. Abdominal aortic aneurysm, AAA.
Absolutely critical. Can be completely asymptomatic until it ruptures, or might present with vague abdominal or back discomfort, maybe a pulsatile mass found on examination.
The screening is important here, especially with family history.
Yes. Family history is a major risk factor. Screening ultrasound is often recommended for first-degree relatives, usually men over 65 or slightly younger if strong family history. The risk of rupture relates directly to the diameter.
What are the key diameters to know?
Normal aorta is less than 3 centimeters. An aneurysm is generally defined as over 3 centimeters. Referral to vascular surgery is usually considered around 4 to 4.5 centimeters, maybe sooner depending on rate of expansion or symptoms. Surgery is generally recommended for aneurysms 5.5 centimeters or larger in men, maybe slightly smaller in women, around 5 centimeters.
And rupture.
A catastrophic surgical emergency. Sudden onset of severe abdominal pain, often radiating to the back or groin, associated with circulatory collapse, hypotension, tachycardia. Patients might literally collapse, sometimes classically described as happening while straining on the toilet, needs immediate recognition and transfer.
Okay, another vascular emergency in the elderly? Mesenteric artery occlusion.
Yes, acute mesenteric ischemia. Devastating if missed. Can be caused by an embolus, often from atrial fibrillation, lodging in the superior mesenteric artery, or by thrombosis of an existing atherosclerotic plaque. Less commonly, non-occlusive mesenteric ischemia in shock states, or venous thrombosis.
How does it typically present?
The classic description is sudden, severe, diffuse abdominal pain, often central or periumbilical, that seems dramatically out of proportion to the physical findings initially. The abdomen might even feel soft early on.
Pain out of proportion. That's the key phrase.
It really is. Patients often develop a fear of eating because it worsens the pain. Intestinal angina in chronic cases. Profuse vomiting, watery, or bloody diarrhea can occur. Confusion is common.
And later signs, when infarction sets in.
Then you start to get the signs of peritonitis, localized tenderness, rigidity, absent bowel sounds, signs of shock. Unfortunately, by this stage, the prognosis is often poor.
Diagnosis is tough.
Can be. Need a high index of suspicion. Lab tests might show a metabolic acidosis, raised lactate, high white cell count. Plain x-rays are often normal initially, maybe show thumbprinting later due to bowel wall edema. CT angiography is the investigation of choice, shows the occlusion.
Good treatment.
Urgent surgical intervention is crucial, either embolectomy, bypass grafting, or angioplasty stenting to restore blood flow if possible. Often requires bowel resection if infarction has occurred. Early diagnosis is key.
Okay, let's switch tracks slightly. Acute retention of urine can cause significant lower abdominal pain, right?
Definitely. A tense, distended bladder is painful, unless perhaps the patient has significant cognitive impairment or chronic retention where the bladder has stretched gradually.
What are the common causes in older people?
In men, benign prostatic hyperplasia, BPH, or acute prostatitis are very common. Fecal impaction is a big one in both sexes. The impacted stool presses on the bladder outlet. Pelvic masses. Medications are a frequent culprit: anticholinergics, opioids, some antidepressants.
Even things like cold exposure or excess alcohol.
Yes, they can precipitate retention. And underlying neurogenic causes, like from diabetes or spinal cord issues. History and examination, including a rectal exam to check the prostate and for fecal impaction. Then, urinary catheterization is usually needed immediately to relieve the pressure and pain, address the underlying cause, treat constipation, review medications. Urology opinion is often needed, especially for men with prostate issues. Maybe a trial without catheter later if it was thought to be drug-induced or transient.
And you mentioned fecal impaction. That can cause pain on its own or even mimic obstruction.
Absolutely, especially in frail, elderly, or bedridden patients. Can cause significant abdominal distension and discomfort, sometimes colicky pain. It can look surprisingly like a malignant large bowel obstruction, and watch out for spurious diarrhea liquid stool leaking around a hard-impacted mass.
Good point. Now, appendicitis in older people, we touched on it, but worth reiterating the challenges.
Yes. The presentation is often minimal, atypical. Pain might be less severe, less localized, might present more like a general intestinal obstruction picture. This often leads to delayed diagnosis.
And higher rates of perforation.
Exactly. Because the diagnosis is made later and perhaps the inflammatory response is less robust initially, perforation rates are significantly higher in the elderly compared to younger adults. Higher morbidity and mortality, too. Need to keep it in mind even with subtle signs.
Okay, let's talk obstructions. Small bowel obstruction, SBO, in older people. Common causes.
Adhesions from previous surgery are the #1 cause overall. Strangulated hernias, inguinal, femoral, incisional are another major cause, especially those that become irreducible. Less commonly, tumors or strictures.
Murtagh's table 24.6 compares high versus low SBO. What are the key differences?
High SBO, closer to the stomach, tends to cause more frequent, intense spasms of pain. Vomiting starts earlier and is often profuse, maybe bilious. Dehydration can develop quickly. Distension is less marked initially. Low SBO, further down the ileum, the pain might be less intense but still colicky. Vomiting occurs later and might become faculent as bowel contents back up. Distension is usually more prominent.
Clinical features overall for SBO.
Severe colicky pain, usually epigastric or periumbilical, vomiting, and absolute constipation, inability to pass feces or flatus. That obstipation is key.
What about signs on examination?
Patient often looks distressed, maybe dehydrated, might see visible peristalsis rippling across the abdomen in thin patients. Auscultation often reveals loud, high-pitched bowel sounds, borborygmi, especially during pain spasms, sometimes described as tinkling. Abdomen might be tender, but often remains soft initially unless strangulation occurs. Need to meticulously check all hernial orifices, inguinal, femoral, umbilical, incisional scars. Rectal exam is usually empty.
Key investigations.
Plain abdominal x-ray, both supine and erect, or lateral decubitus. Look for dilated loops of small bowel, usually 2.5–3 centimeters, often arranged in a stepladder pattern on the erect film with multiple air fluid levels. CT scan is often used now, more sensitive and specific, can show the transition point and potentially the cause and signs of strangulation. A gastrograph and follow-through study can sometimes be diagnostic and even therapeutic in adhesive SBO.
And management.
Initial management is resuscitation and stabilization. Drip and suck intravenous fluids to correct dehydration and electrolytes, and a nasogastric tube on free drainage or low suction to decompress the stomach and bowel, reducing vomiting and distension. Analgesia. Most cases of complete SBO, especially if strangulation is suspected, will require surgery, usually a laparotomy, to relieve the obstruction, resect non-viable bowel if needed. Conservative management might be tried initially for suspected adhesive SBO if there are no signs of strangulation.
Okay, now large bowel obstruction, LBO. Common causes in older adults.
Colorectal cancer is the most common cause, particularly sigmoid colon cancer. Acute diverticulitis causing inflammation and stricture is another major cause. Volvulus twisting of the bowel on its mesentery, usually sigmoid volvulus, less commonly cacal volvulus, fecal impaction, as we mentioned.
How does the pain differ from SBO typically?
Generally develops more gradually, might be less severe initially compared to SBO, often described as colicky but located lower down in the hypogastrium or across the lower abdomen. It's really important to rule out non-surgical causes of constipation before jumping to LBO.
Clinical features.
Often a more gradual onset of colicky lower abdominal pain. Vomiting is typically a late feature or might be absent altogether, especially if the ileocecal valve is competent, preventing reflux into the small bowel. Absolute constipation and inability to pass flatus are usually present. Abdominal distension is often the most prominent feature and can become quite marked early on.
Examination findings.
Obvious distension. Bowel sounds might be increased initially, then become quieter. Localized tenderness or rigidity might suggest ischemia or perforation. Rectal exam is crucial, might reveal an obstructing tumor or impacted feces.
Investigations for LBO.
Plain abdominal X-ray is key. Shows dilated large bowel loops proximal to the obstruction. You can often see the haustral markings, which distinguish large bowel from small bowel. Look for cacal distension. If the cacum is 9–10 centimeters, there's a high risk of perforation. In sigmoid volvulus, you might see the classic massive loop of dilated sigmoid rising out of the pelvis, the coffee bean sign. Cacal volvulus often shows a dilated cacum displaced to the epigastrium or left upper quadrant. A water-soluble contrast enema, like gastrographin or CT scan, can help delineate the site and cause of obstruction. Again, initial management involves drip and suck IV fluids, NG tube if vomiting, correction of electrolyte imbalances. Urgent surgical referral is usually necessary. The specific management depends on the cause resection for cancer, Hartmann's procedure for perforated diverticulitis, detorsion, and possible resection for volvulus. Sometimes endoscopic decompression can be attempted for sigmoid volvulus initially.
Okay, moving to another surgical emergency. Perforated peptic ulcer.
Yes, a classic acute abdomen, usually a sudden dramatic onset. Risk factors include H. pylori infection, NSAID use, smoking, sometimes precipitated by a large meal or alcohol.
How does it present? The pain.
Sudden onset of severe, constant epigastric pain, often described as like being stabbed or burning. It rapidly becomes generalized across the entire abdomen as gastric or duodenal contents spill into the peritoneal cavity.
Can it radiate?
Yes, often radiates to one or both shoulders, particularly the right, due to diaphragmatic irritation from the leaked contents tracking up the pericolic gutters. Sometimes pain can track down to the right iliac fossa, mimicking appendicitis.
Nausea, vomiting.
It's usually delayed. The initial shock and pain are paramount. Hiccups can be a late feature due to diaphragmatic irritation.
And the examination findings. They're quite characteristic, aren't they?
Very. The patient typically lies absolutely still, often with knees drawn up, because any movement exacerbates the intense pain. They look unwell, pale, maybe sweating. The hallmark sign is generalized abdominal rigidity. The abdomen feels board-like hard due to involuntary guarding from the intense peritoneal irritation.
Where is the tenderness maximal?
Usually maximal over the site of perforation, often epigastric for a duodenal ulcer, but it rapidly becomes generalized. Distension isn't usually a feature early on. Bowel sounds are typically reduced or absent due to the peritonitis causing an ileus.
Shifting dullness. Vital.
Shifting dullness might develop later as fluid accumulates. Vital signs might be surprisingly normal initially due to a vasovagal response, but tachycardia, hypotension, and signs of shock usually develop as chemical peritonitis progresses to bacterial peritonitis. Breathing is often shallow because deep breaths hurt. Pelvic tenderness on rectal or vaginal exam in the pouch of Douglas is common.
Investigations. How do we confirm it?
An erect chest X-ray is the crucial first-line test. Look for free air under the diaphragm, lumoperitoneum. It's present in about 70–80% of cases. If the chest X-ray is negative but suspicion is high, a CT scan is the most sensitive test for detecting small amounts of free air and fluid. A limited water-soluble contrast study, gastrographin meal, might be used sometimes, but CT is generally preferred. This is an immediate surgical emergency. Needs rapid resuscitation, IV fluids, oxygen, urgent pain relief, opioids, nasogastric tube to decompress the stomach, broad-spectrum intravenous antibiotics to cover likely contamination, and then prompt surgical intervention, usually laparotomy or sometimes laparoscopy, to identify the perforation, wash out the peritoneal cavity, and repair the hole, often with an omental patch called a Graham patch.
Okay. Let's talk about colic again, but this time ureteric colic. Very different cause, equally severe pain often.
Yes, the pain of passing a kidney stone down the ureter can be excruciating. Typically presents as sudden onset of severe colicky pain, starting in the loin, costovertebral angle, and radiating anteriorly down towards the groin, flank, testicle in men, or labia in women.
Why colicky? Does it come and go?
The term colic refers to the wave-like spasms of the ureter trying to propel the stone downwards. So the pain intensity often fluctuates, coming in severe waves lasting minutes to hours, although sometimes it can be more constant. Patients are often incredibly restless, constantly moving, unable to find a comfortable position, very different from the still patient with peritonitis.
Associated symptoms?
Nausea and vomiting are very common due to the shared nerve supply between the kidney ureter and the gut. Patients might look pale, sweaty, clammy during the intense pain.
Examination findings.
Often marked tenderness on palpation or percussion over the costovertebral angle, CVA tenderness, on the affected side. Abdominal exam might be relatively unremarkable, maybe some muscle spasm in the flank. Urine dipstick is crucial, usually shows microscopic or macroscopic hematuria, blood in the urine, though absence of hematuria doesn't completely rule it out.
Diagnosis. How do we confirm the stone?
Urine microscopy confirms hematuria, might show crystals. Basic bloods, FBC, UNEs, calcium urate. Imaging is key. A plain abdominal X-ray, KUB, kidneys, ureters, bladder, can show radio-opaque stones, calcium-based stones, about 80–90%, but it misses radiolucent stones, like uric acid stones, and doesn't show obstruction well. Ultrasound is good for looking at the kidneys, hydronephrosis, and bladder, but often misses stones in the mid-ureter. Intravenous pyelography, IVP, used to be common but is less so now.
So what's the gold standard now?
Non-contrast helical CT scan of the kidneys, ureters, and bladder, CT-KUB. It's fast, doesn't require contrast, and is highly sensitive and specific for detecting stones of all types and sizes, their location, and signs of obstruction like hydronephrosis or periureteric stranding.
Management of acute ureteric colic. Pain relief is paramount.
Absolutely. Potent analgesia is needed. Opioids like morphine or fentanyl are often required. NSAIDs like intravenous or intramuscular ketorolac or rectal diclofenac are also very effective as they reduce ureteric spasm and inflammation. Often a combination is used. Antiemetics for nausea vomiting.
What about fluids, push fluids?
Actually, in the acute phase of severe pain and obstruction, forcing fluids is generally avoided as it can increase pressure proximal to the stone and worsen pain and potentially cause fornicial rupture. Once the acute pain settles, then encouraging good fluid intake is important to help flush the stone through.
Any role for alpha blockers like tamsulosin?
Yes, medical expulsive therapy, MET, with alpha blockers like tamsulosin is often used for stones in the distal ureter, typically 10 millimeter, to help relax the ureteric smooth muscle and facilitate spontaneous passage.
When do we need to refer to urology urgently?
Signs of infection proximal to an obstructing stone, pyonephrosis, that's a urological emergency requiring urgent drainage. Uncontrolled pain despite adequate analgesia. Significant renal impairment. For example, a solitary kidney with obstruction, bilateral obstruction. Stone size unlikely to pass spontaneously, generally 7–10 millimeter. Persistent obstruction.
Good summary. And just briefly, some facts about urinary stones.
Relatively common, affect maybe 5–10% of people. Recurrence is high, around 50% within 5–10 years. Risk factors include dehydration, family history, certain diets, high oxalate, high sodium, high animal protein. Some medical conditions, hyperparathyroidism, gout, IBD, and some medications. Most stones are calcium oxalate.
Okay. Let's move to the upper abdomen again, biliary pain and acute cholecystitis.
Right. Common issues, often related to gallstones. Let's start with biliary colic. This is the pain caused by a gallstone temporarily obstructing the cystic duct or passing through the common bile duct.
How does it present?
Typically, acute onset of severe constant pain, usually in the right upper quadrant, RUQ or epigastrium, often occurs after eating, particularly a fatty meal, or can wake the patient at night. The pain often builds up over minutes, plateaus, and then gradually subsides, usually lasting from 20 minutes up to maybe 6 hours. If it lasts longer, you start thinking cholecystitis.
Where does the pain radiate?
Classically radiates around the right side to the back, often to the inferior angle of the right scapula or the right shoulder tip. Patients might find some relief by leaning forward or being in a flexed posture. Nausea and vomiting are common. Often there's a history of previous similar, maybe milder episodes.
Examination findings in biliary colic.
Patient might appear anxious, restless, maybe trying to find a comfortable position. Localized tenderness in the RUQ or epigastrium is common. Murphy's sign, the sharp inspiratory arrest when palpating deeply under the right costal margin, is typically negative in simple biliary colic, or only mildly positive. If it's strongly positive, that suggests cholecystitis.
Diagnosis.
Abdominal ultrasound is the investigation of choice, highly sensitive for detecting gallstones within the gallbladder. It might also show common bile duct dilatation if a stone has passed into the duct. Liver function tests, LFTs, might show a transient rise in bilirubin or alkaline phosphatase, ALP, if there was temporary bile duct obstruction, but are often normal in simple colic.
Management of biliary colic.
Pain relief is key opioids or NSAIDs as for renal colic, antiemetics if needed. If stones are confirmed and the patient is symptomatic, the definitive treatment is elective laparoscopic cholecystectomy to prevent further episodes and complications like cholecystitis or pancreatitis. Medical dissolution therapy or lithotripsy have very limited roles now.
And not all gallstones cause symptoms, right?
Correct. Many people have asymptomatic gallstones found incidentally. We generally only treat symptomatic stones. Also worth remembering, microlithiasis, tiny stones, or biliary sludge, which can cause typical biliary pain even if larger stones aren't seen on ultrasound.
Okay, so what happens when it progresses beyond simple colic to acute cholecystitis? What's the pathophysiology there?
Acute cholecystitis occurs when a gallstone becomes impacted in the cystic duct and doesn't dislodge. This persistent obstruction leads to inflammation of the gallbladder wall. Initially, it might be chemical inflammation from concentrated bile, but secondary bacterial infection often occurs with gut organisms.
How does the clinical picture differ from biliary colic?
The pain is usually more persistent and severe, lasting longer than 6 hours. It's typically a steady ache in the RUQ or epigastrium, often radiating to the right infrascapular area. It's often aggravated by movement or deep inspiration, breathing. Anorexia, nausea, and vomiting are common. Fever is often present. There's usually a history of gallstones and previous biliary pain.
Examination findings in acute cholecystitis.
The patient often lies still, unlike the restless patient with colic, as movement worsens the pain. Marked localized tenderness in the RUQ. Murphy's sign is classically positive sharp pain and inspiratory arrest on palpation. Guarding and sometimes rebound tenderness in the RUQ indicate localized peritonism. The gallbladder might be palpable in about 15% of cases, a mass. Mild jaundice might be present in about 15%, maybe due to surrounding inflammation compressing the common bile duct, Murtagh syndrome, or a concurrent stone in the duct. Fever is common. Blood tests usually show an elevated white cell count in CRP. LFTs might be mildly elevated. Ultrasound is key. It confirms gallstones, but also looks for signs of cholecystitis like gallbladder wall thickening, 3-4 millimeter, pericholecystic fluid, and a sonographic Murphy's sign, maximal tenderness, directly over the gallbladder. If the diagnosis is uncertain, a HID scan, coloscintigraphy, can be very helpful. Failure of the gallbladder to visualize after tracer injection indicates cystic duct obstruction.
Treatment for acute cholecystitis.
It requires hospital admission. Management includes bowel rest, NPO, intravenous fluids, analgesia, opioids often needed, and intravenous antibiotics, covering common gut organisms like E. coli, Klebsiella, Enterococcus. Definitive treatment is cholecystectomy, ideally performed laparoscopically during the same hospital admission, usually within the first few days once the initial inflammation starts to settle, early cholecystectomy. Delayed cholecystectomy might be planned if presentation is late or the patient is unstable.
Okay. Let's move just nearby anatomically to acute pancreatitis,
Yeah.
another cause of severe upper abdominal pain. Associations.
Gallstones and excessive alcohol consumption are the two most common causes by far, accounting for maybe 80% of cases. Gallstones cause it by temporarily obstructing the ampulla of Vater, where the pancreatic duct joins the common bile duct. Other causes include high triglycerides, hypertriglyceridemia, certain medications like azathioprine, valproate, some diuretics, gliptins, post-ERCP procedure, trauma, viral infections like mumps, rarer causes like hypercalcemia, pancreas divizum, autoimmune pancreatitis, or idiopathic.
How does the pain present?
Typically sudden onset of severe, constant, deep pain in the epigastrium, often radiating straight through to the back, described as like a band across the upper abdomen. Patients often find some relief by sitting upright and leaning forward.
Associated symptoms.
Nausea and persistent vomiting are very common. Sweating, weakness, anxiety.
Examination findings.
Patient often looks unwell, pale, sweaty, anxious, maybe tachycardic. Marked epigastric tenderness is usually present. However, significant guarding, rigidity, or rebound tenderness are often absent early on, which can be a helpful distinguishing feature from a perforated viscus, although some guarding might develop. Bowel sounds are often reduced or absent due to an associated ileus. Abdominal distension can occur. Fever might be present. In severe cases, signs of shock, hypotension, tachycardia, oliguria can develop due to massive fluid shifts, third spacing, and release of inflammatory mediators.
Any specific signs to look for in severe pancreatitis?
Rarely, you might see Cullen's sign, periumbilical bruising, or Gray-Turner's sign, flank bruising, due to retroperitoneal hemorrhage in severe necrotizing pancreatitis, but these are late signs.
Diagnosis. Key blood tests.
Serum amylase and lipase levels are crucial, typically elevated to at least 3 times the upper limit of normal. Lipase is generally considered more specific and stays elevated for longer than amylase. Elevated white cell count and CRP are usual. Look for other potential clues. Abnormal LFTs might suggest gallstone pancreatitis, high glucose, low calcium due to fat saponification. Check triglycerides. Arterial blood gases might show hypoxia or acidosis in severe cases.
Imaging.
Plain abdominal X-ray is often done to exclude other causes like perforation, free air, or obstruction, might show a sentinel loop, localized ileus near the pancreas, or colon cutoff sign. Ultrasound is useful primarily to look for gallstones as a potential cause and maybe complications like pseudocysts later on. Contrast-enhanced CT scan is the best imaging modality for assessing the severity of pancreatitis, for example, using the Balthazar score, detecting necrosis, and identifying complications. However, CT is usually deferred for at least 48-72 hours after onset unless the diagnosis is uncertain, as the full extent of necrosis might not be apparent earlier.
Management of acute pancreatitis.
Requires hospital admission, often to a high dependency or intensive care unit if severe. Management is primarily supportive. Aggressive intravenous fluid resuscitation is critical, especially in the first 24-48 hours. Strict NPO initially to rest the pancreas. Nasogastric suction might be used if vomiting is persistent or ileus is present. Effective analgesia is crucial, often requiring opioids like morphine or fentanyl via PCA. Monitor fluid balance, oxygen saturation, glucose, calcium, renal function closely. Nutritional support, enteral feeding via nasojunal tube, preferred over parenteral nutrition if possible, should be started early if the patient is unable to eat for several days.
What about antibiotics?
Prophylactic antibiotics are generally not recommended in mild or moderate pancreatitis. They are usually reserved for proven or strongly suspected infected pancreatic necrosis.
And if gallstones are the cause?
If gallstone pancreatitis is suspected, particularly if there's evidence of ongoing biliary obstruction, jaundice, cholangitis, dilated bile duct, then urgent ERCP, endoscopic retrograde cholangiopancreatography, with sphincterotomy and stone extraction might be indicated within the first 24-72 hours. Cholecystectomy should be performed during the same admission once the pancreatitis settles to prevent recurrence.
Okay. Briefly, chronic pancreatitis and pancreatic cancer, how does the pain differ?
Chronic pancreatitis pain is often milder than acute attacks, but more persistent or relapsing. Still typically epigastric radiating to the back. Patients might develop features of pancreatic insufficiency over time, malabsorption, steatorrhea, weight loss, and diabetes. Investigations include CT, MRCP, fecal elastase. Pancreatic cancer pain can be similar but is often more severe, relentless, and predominantly felt in the back. Often associated with significant weight loss, jaundice, if head of pancreas tumor obstructs bile duct.
Management focuses on pain control and enzyme supplements.
Yes, managing pain, often challenging, and replacing pancreatic enzymes to help with digestion and absorption are key aspects of managing chronic pancreatitis and sometimes advanced pancreatic cancer.
Right, let's move to the left lower quadrant now. Acute diverticulitis.
Very common, especially in older adults in Western countries. Affects those with diverticulosis the presence of outpouchings, diverticula, in the colon wall, usually the sigmoid colon. Diverticulitis is inflammation or infection of one or more of these diverticula.
Typical patient profile.
Usually over 40, often over 60. May have a history of altered bowel habits, like intermittent left-sided abdominal pain or constipation related to underlying diverticulosis.
How does acute diverticulitis present?
Acute onset of constant pain, usually localized to the left iliac fossa, LAF. Pain is often described as aching or sharp and may be increased by movement, usually associated with change in bowel habit, often constipation, but sometimes diarrhea. Anorexia, nausea, and sometimes vomiting can occur. May have urinary symptoms like frequency or dysuria if the inflamed sigmoid irritates the bladder.
Examination findings.
Localized tenderness, guarding, and potentially rigidity in the LALF. Fever is common. A tender inflammatory mass might be palpable in the LAF in some cases. Rectal exam might reveal tenderness anteriorly.
Investigations.
Blood tests usually show leukocytosis and elevated ESR or CRP. Stool might show occult blood, occasionally frank blood, but significant bleeding is more common with diverticulosis itself, diverticular bleeding rather than acute diverticulitis. Imaging is key to confirm the diagnosis and look for complications. CT scan with intravenous and oral contrast as the investigation of choice shows thickened colonic wall, pericolic fat stranding, and can identify complications like abscesses or perforation. Ultrasound can be used but is less sensitive than CT, especially for complications. Plain X-rays are usually done to look for free air, perforation, or obstruction.
What are the potential complications?
Perforation can be contained or free, leading to peritonitis. Abscess formation, pericolic or pelvic. Fistula formation, for example, colovesical fistula to the bladder, colovaginal. Bowel obstruction, due to inflammation or subsequent stricture formation. Bleeding, though less common in acute inflammation.
Treatment approach.
Depends on severity. Mild, uncomplicated diverticulitis, Hinchey stage 1A, can often be managed on an outpatient basis with clear fluids initially, then low-residue diet, and oral antibiotics covering gram-negative rods and anaerobes, for example, ciprofloxacin plus metronidazole or coamoxiclav, analgesia. Some guidelines now suggest antibiotics might not be necessary for all mild and complicated cases, with close monitoring. Wait and see. More severe cases, significant pain, fever, inability to tolerate oral intake, signs of complications, comorbidities, immunosuppression, require hospital admission for 5E fluids, 5E antibiotics, bowel rest, analgesia.
When is surgery needed?
Surgery, usually resection of the affected sigmoid colon, often with a temporary or permanent stoma like a Hartmann's procedure, is indicated for complications like generalized peritonitis due to free perforation, large undrainable abscesses, fistula, obstruction, or failure of medical management, or sometimes for recurrent severe attacks. Percutaneous drainage under CT guidance might be possible for localized abscesses.
And follow-up.
After an episode of acute diverticulitis resolves, a colonoscopy is usually recommended, typically 6 to 8 weeks later, to confirm the diagnosis, assess the extent of diverticulosis, and importantly, to exclude an underlying colorectal cancer, which can sometimes mimic or coexist with diverticulitis.
Okay, briefly, peritonitis in the abdominal stitch.
Generalized peritonitis, as we've seen, is usually due to perforation of a viscous ulcer, appendix, diverticulum, bowel. Presents with severe generalized pain, rigidity, absent bowel sounds, signs of sepsis. Investigations include bloods, imaging, X-ray CT for free air source. Treatment is resuscitation, broad-spectrum antibiotics, and urgent surgery to control the sores and wash out the abdomen. Spontaneous bacterial peritonitis, SBP, is different, occurs in patients with pre-existing ascites, usually due to cirrhosis, presenting with fever, abdominal pain, worsening ascites, confusion, needs diagnostic paracentesis and antibiotics.
And the stitch.
Exercise-related transient abdominal pain, ETP. Sharp stabbing pain, usually in the side during running or exertion. Cause isn't entirely clear, maybe diaphragmatic ligament strain or peritoneal irritation. Management is simple. Stop or slow down, deep breaths, stretch the affected side, gentle massage. Usually resolves quickly on resting.
Right. Now, briefly touching on chronic or recurrent abdominal pain in adults, diagnostics have improved.
Yes, things like advanced imaging, CT, MRI, enterography, capsule endoscopy, better serological tests have helped. But the principles remain. Thorough history and examination, look for red flags.
Remind us of the red flags in adults with chronic or recurrent pain.
New onset symptoms, especially in someone over 50. Nocturnal symptoms, pain or diarrhea waking from sleep. Progressive worsening of symptoms. Unintentional weight loss. Rectal bleeding or melena. Iron deficiency, anemia. Persistent vomiting. Abdominal mass on examination. Recent onset fecal incontinence or urgency. Family history of IBD or colorectal cancer. These warrant thorough investigation.
Other investigations might include
Beyond basics, bloods, stool tests, coeliac serology, might consider endoscopy, upper and or lower, imaging, ultrasound, CT, MRI, sometimes laparoscopy if diagnosis remains elusive despite investigation. We should also briefly mention chronic appendicitis, a controversial entity, but sometimes considered. And pain from adhesions after previous surgery is a common cause of chronic or recurrent obstructive symptoms or pain.
And peptic ulcers can cause chronic or recurrent pain, too.
Yes. Classic epigastric burning pain. Duodenal ulcer, DU pain often occurs 2-3 hours after meals or wakes the patient at night, hunger pain, often relieved by food or antacids. Gastric ulcer GU pain relationship to food is more variable, sometimes worse soon after eating. H. pylori testing and or endoscopy are key for diagnosis.
Okay, this has been incredibly detailed. Let's distill it down. When do we absolutely need to refer a patient with abdominal pain?
Some clear indications for immediate, urgent referral, usually to the emergency department or surgical team on call. Any suspicion of an acute surgical emergency, things we've discussed like ruptured ectopic, ruptured AAA, mesenteric ischemia, perforated viscous, obstructed or strangulated bowel, and susception, acute appendicitis with peritonism, severe acute cholecystitis, or pancreatitis.
So basically anything needing urgent surgery.
Exactly. And also, obviously, all cases that are ultimately deemed to need surgical intervention, even if less emergent, like elective repair of hernia or cholecystectomy.
What about complex medical causes?
Yes, conditions like diabetic ketoacidosis, DKA, or acute intermittent porphyria presenting with abdominal pain often require specialist medical input for management, so referral is appropriate.
And if we're just not sure?
Absolutely. If the cause of acute abdominal pain remains unclear after your initial assessment, especially if the patient seems unwell or the pain is severe, have a low threshold for referral for a second opinion or further investigation in a hospital setting. Better safe than sorry.
That's really helpful advice.
Yeah.
Do you have any final practice tips or pearls for our listeners, especially those facing exams?
Yes, a few key takeaways. First, always exercise extra caution at the extremes of age, the very young and the elderly. Presentations are often atypical, serious pathology, more common or easily missed.
Good point.
Second, remember those causes of intense acute pain in the elderly. Always think mesenteric occlusion, acute pancreatitis, and ruptured or dissecting AAA. High mortality if missed. Third, be aware of that temporary pain relief that can occur after an appendix ruptures. It can be falsely reassuring. The pain often returns worse as generalized peritonitis sets in.
The calm before the storm.
Kinda, yes. Fourth, nocturnal abdominal pain that wakes the patient is always significant. Think gallstones, duodenal ulcer, sometimes malignancy, needs investigation.
Right.
Fifth, remember that appendicitis can cause urinary symptoms or findings like pus or red cells in the urine if the inflamed appendix lies near the bladder or ureter. Don't let a dirty urine rule out appendicitis if the clinical picture fits.
Good clinical pearl.
And finally, never forget DKA. Abdominal pain, tenderness, even rigidity can be prominent features, often accompanied by deep sighing respiration, small breathing. Always check a blood glucose in patients presenting like this, especially if known diabetic or high risk.
Excellent tips. Thank you. So, to summarize this really comprehensive deep dive into abdominal pain, the key message seems to be that a systematic, thoughtful approach is absolutely crucial.
Definitely. Start broad, consider probabilities, but always actively rule out the serious stuff.
Consider the probability diagnoses based on age, history, exam, but maintain that high index of suspicion for the not-to-be-missed conditions. Be really mindful of those diagnostic pitfalls. And remember how much the presentation can vary across different age groups.
A careful history, a thorough physical examination, and the judicious use of appropriate investigations, they remain your most valuable tools. No substitute for good clinical skills.
Absolutely. And for all of you GPs and registrars preparing for your fellowship exams, this in-depth understanding covering the common stuff, the critical red flags, the nuances across ages, the pathophysiology, it isn't just academic. It's the bedrock for confidently and competently managing this incredibly frequent and sometimes life-threatening presentation throughout your careers.
Couldn't agree more. This is core general practice.
And while we have covered a huge amount today, it's important to acknowledge that abdominal pain can still throw curveballs. Diagnostic uncertainty is part of medicine.
Always will be.
So cultivating that strong clinical intuition, maintaining that high index of suspicion, especially for red flags in invulnerable populations, that remains paramount. We encourage you to keep learning, keep questioning, keep critically appraising presentations, and never ever hesitate to seek advice or refer when you're unsure.
Well said. And for those listeners who want to consolidate this and really visualize some of these conditions, we strongly recommend going back to John Murtagh's general practice and reviewing the tables we mentioned, 24.1, 24.2 for the overall approach, 24.5 comparing appendicitis and mesenteric adenitis, 24.6 comparing high and low SBO, and look at the figures too. They illustrate many of the conditions beautifully, like AAA, figure 24.6, intussusception, figure 24.3, bowel obstruction patterns, figure 24.9, 24.0, free air, fig 24.11, ureteric colic imaging, fig 24.13, gallstones on ultrasound, fig 24.13, pancreatitis on CT, figure 24.15, really helps cement the knowledge.
A fantastic resource. Thanks for highlighting those specific figures and tables. Well, that brings us to the end of this deep dive. Until next time, keep thinking critically and keep learning.